Welcome to the Breast and Regional Lymphatics lecture. First, we'll start with structure and function. Please note the surface anatomy, focusing on the location of the breast on the chest wall itself, locating the axillary tail of Spence, and the nipple and areola areas. The breasts are mammary glands, and they're associated with being a reproductive organ. The function itself is to produce milk for nourishing the newborn. The breast lies anterior to the pectoralis major and serratus anterior muscles, and they're located between the second and the sixth rib, as you can see on the diagram. This extends from the side of the sternum to that mid-axillary line. The superior lateral corner of that breast tissue, this is what we call the axillary tail of Spence, and I want you to look up the significance of that area. The tail of Spence projects up and lateral into the axilla. Now, the nipple itself is just below the center of the breast. It is a rough round and usually protuberant. Its surface looks wrinkled and indented with tiny milk duct openings if you looked closely. The areola surrounds the nipple for about 1 to 2 centimeter radius. The areola also has smooth muscle fibers that cause the nipple erection when stimulated, and both the nipple and areola are more darkly pigmented than the rest of the breast surface, and this color varies from light pink to brown depending on the person's skin color and parity, meaning the condition of giving birth. As they are closer to giving birth, typically, but not always, the pigmentation of the areola will become darker. Breasts are also present in men too, although rudimentary throughout life. The breast has glandular tissue, but it also has fibrous tissue. This includes the suspensory ligaments and also the adipose tissue. The glandular tissue contains 15 to 20 lobes radiating from the nipple, and these are composed of lobules. Within each lobule are clusters of alveoli, and these alveoli produce milk. Now, each lobe empties into a lactiferous duct, and there's about 15 to 20 of these ducts that form a collecting duct converging toward the nipple, and this is how milk is excreted during breastfeeding. Through the ducts from the ampullae or lactiferous sinuses behind the nipple, they're reservoirs for storing milk. Now we're going to move on to the suspensory ligaments. These are also called the Cooper ligaments. They're fibrous connective tissues, and they extend vertically from the skin surface to attach on the chest wall muscles. They support the breast tissue, and that's why as we age, we have a decrease in support of breast tissue because these ligaments are not as strong. The lobes are embedded in adipose tissue, and these layers of sub-Q and retromammary fat, actually they provide most of the bulk of the breast tissue. The relative proportion of glandular, fibrous, and fatty tissue will vary depending on the age, the cycle of pregnancy, menstrual cycle, lactation, and just overall general nutritional status. There are 4 quadrants of the breast. The breast may be divided in these 4 quadrants by imaginary horizontal and vertical lines intersecting at the nipple. This makes it a convenient way to map out or describe clinical findings. In the upper quadrant, note the axillary tail of Spence. The cone-shaped breast tissue in the tail of Spence projects up to the axilla, close to the pectoral group of the axillary lymph nodes. The upper outer quadrant is the site of most breast tumors. Now we're looking at the lymphatic system. There are central axillary nodes high up in the middle of the axilla over the ribs and the serratus anterior muscle. These receive lymph from other groups of nodes, 3 other ones. We also see the pectoral or the anterior. Along the lateral edge of the pectoralis major muscle just inside the anterior axillary fold. There's also posteriorly the subscapular, along the lateral edge of the scapula, deep in the posterior axillary fold. And then lastly, the lateral, which is along the humerus inside the upper arm. Now, from the central axillary node, drainage flows up to the infraclavicular and supraclavicular nodes. A small amount of lymphatic drainage does not take these through the channel, but instead it flows directly up to the infraclavicular group, or deep into the chest, or into the abdomen, or directly across to the opposite breast. So please spend some time looking at this drainage pattern, and you can see it moves all the way upward to the supraclavicular area. Now, if we're thinking about developmental care, with the adolescent at puberty, it's estrogen, the hormone that stimulates breast changes. The breasts enlarge mostly as a result of extensive fat deposited in this area. The duct system also grows, it branches, and the masses of small solid cells develop at the duct endings. These are the potential alveoli. Now, occasionally, which is normal, one breast may grow faster than the other, producing a temporary asymmetry. This sometimes causes distress in the adolescent, so please reassure that this is normal. Tenderness is also common, although what is not always the same is the age of onset. It actually varies widely. There are 5 stages of breast development, and we use the Tanner staging, which you can see in the next slide, to help determine and describe the sexual maturity. So this is a sexual maturity rating table, Tanner staging. Now, in the pregnant woman, during pregnancy, breasts also change. They start during the 2nd month and are a common early sign of pregnancy. Doesn't mean that they are pregnant, but it could be an early sign that they are. Pregnancy stimulates expansion of the ductal system, supporting the fatty tissue and the development of the true secretory alveoli. So these are alveoli that are going to actually produce milk. The breasts enlarge and they feel more nodular during this time. The nipples will grow, they will become darker, and they often will become more erect. They're all getting ready for breastfeeding. The areolae become larger and a darker brown as pregnancy progresses, and the tubercles become more prominent. The brown color actually will fade after lactation, but the areolae, they typically never return to that original color, just become lighter. A venous pattern is prominent over the skin surface. This thick yellow fluid that will come forth during the last step of pregnancy is called colostrum, and it's a yellow fluid. This is the precursor for milk, sometimes referred to as liquid gold. Colostrum has a lot of protein and lactose, but it doesn't have fat. The breast produces colostrum for the first few days after delivery, and this is rich in antibodies that protect the newborn against infection. Therefore, breastfeeding is really important, especially during those first few days, in order to get the colostrum. Then milk production, or true lactation, begins 1 to 3 days after delivery. The whitish color is from emulsified fat and calcium caseinate. Now, in the aging woman, after menopause, ovarian secretion of estrogen and progesterone will start to decrease, and this is what causes atrophy in the breast tissue. And this is replaced with fibrous connective tissue. That fat envelope atrophies also. And this usually happens in the middle years and becomes pretty prominent in the woman's 70 and 80th years. These changes decrease breast size and elasticity. So this is, again, causing the breast to droop and sag. They look flattened and flabby as we get older. Drooping is then accentuated in most cases by kyphosis in older women. This decreased breast size makes the inner structures more prominent. And actually, breast lumps may have been present for years, but not palpable. And now they're suddenly palpable because of the changes. in skin and tissue. Around the nipple, the lactiferous ducts are more palpable and feel firm and stringy because of the fibrosis. The axillary hair also will start to decrease as well. In the male breast, again, it's a rudimentary structure consisting of thin discs of undeveloped tissue underlying the nipple. The areola is well developed, although the nipple is relatively small, and during adolescence, it is common for breast tissue to enlarge temporarily, producing gynecomastia. The condition is usually temporarily, so please reassure your patients. However, gynecomastia can return and reappear in the aging male, and this could be a result of testosterone deficiency, again in the aging male. Let's talk about breast cancer for a second. Today, a woman with breast cancer is half as likely to die from cancer as she was 30 or 40 years ago. And this is because we have targeted treatments of the estrogen receptor and the HER2 gene. Also, cancer-specific mutations in DNA can be measured with family history. We also know that a certain tumor suppressor gene termed the BRCA, BRCA1 and BRCA2, can suggest an increased risk of breast cancer. Women who inherit this mutation on one or both have a higher risk of developing cancer of the breast and ovaries compared with women that don't have this gene. Screening mammograms can discover small, potential curable breast cancers, and the American Cancer Society recommends that this happens at 40 years old, and then having an annual mammogram. However, there are racial disparities that exist with screening mammograms. We're trying to increase we're trying to increase the screening to decrease the risk across all populations. Another important thing to think about is that our patients with lower income, lower education levels, employment, those that have a lack of health insurance, or that they just have not been educated about the signs and symptoms of breast cancer have a higher risk. Please talk about breast cancer to all your patients that it applies to. There are some lifestyle factors that we need to think about, especially alcohol drinking. This affects breast cancer as well. There have been meta-analyses that have told us that even light drinking, which is considered 3 to 6 drinks per week, increases your risk of breast cancer. Evidence shows that smoking may also slightly increase the risk of breast cancer, especially if you are a long-term heavy smoker and those who start smoking before their first pregnancy. This is all through research. Regular physical activity yields a 10 to 20% lower risk of breast cancer compared to those who are inactive. This is Tanner staging of the breast development we use in mainly female, but if there is abnormal breast development in male or gynecomastia, you could potentially use part of the chart as well. But you see pre-pubertal, you might have elevation of the papilla, but you're not going to see an increase in the alveoli until Tanner stage 2, which is somewhere between 9 and 13 years old. So this has a pretty big range because, again, this estrogen development in puberty that increases breast tissue changes over time, increases the breast tissue, but it starts pretty differently in all patients. If you're interested in the biofeedback loop of lactation, this slide is for you, but you will not be tested on this. Here is the difference between a female breast and a male breast that has dense tissue in it. So in gynecomastia, enlarged breast tissue of the male, there are no lobules. There's no lobules to create milk production. We also use Tanner staging for not only breast tissue, but also pubic hair and genital development as well. Moving on to breast cancer, there are 4 stages of breast cancer depending on the location and the intensity of that breast cancer and where it has progressed. You will not be tested on this as well for health assessment, but I do want you to know that it is staged much like other cancers are. Moving on to the subjective health history, we want to ask about pain and if that pain is localized, is it central, is it in one area, is it cyclical, is it only around the menstrual period? We also want to know if they're on oral contraceptives because cyclical pain is common with normal breasts without breast cancer if they are on oral contraceptives. Sometimes there's benign breast disease or fibrocystic breast tissue. Wherever that pain is, you want your patient to show you where that is. Describe the characteristic. Is it sore to the touch? Is it burning? Is it pulling? Is it worsen if you move in one particular direction or the other with activity or no activity? Do you feel an actual lump? Where is this lump? Is it thickening? Is there any skin changes? This is really important. Is there any discharge? What does the discharge look like? Is it white or is it blood tinged? Does the patient notice any rash, swelling, or has there been any trauma to this area? With health history, you want to know if there is a past history of breast disease, not only in themselves, but family history. Have they had any surgical interventions of the breast tissue? Self-care behaviors. Do they perform a self-examination? And when was their last mammogram, if this applies? And maybe with some patients, you might ask if they've had an ultrasound as well. You also want to talk about the tenderness in their axilla area. Is there any lumps or swelling that they've noticed or any rash? Sometimes the lymph nodes in the axilla will be enlarged after vaccination on the arm. And we saw this a lot with the COVID vaccine. Additional health history, if it's pre-adolescent, you want to know, when did the breast changes start? Are there any discharge or unfamiliar secretions? In a pregnant woman, I want to know if they have noticed an enlargement of breast. And then also I want to talk about breastfeeding. Are there plans to breastfeed in the future? If there are, I want to note if there are inverted nipples because they may need additional lactation support for the infant to be able to latch on to this type of breast. And then any changes in the breast overall, and if they're on HRT, which is hormone replacement treatment, which most menopausal women are, and could change the breast tissue. Moving on to the physical exam, it is quite important that we drape appropriately and we position our patient appropriately, which we'll see in the physical exam. You might use a small pillow. You need something to measure, and you will have the opportunity to use a breast self-exam teaching aid or pamphlet in some facilities. If not, you have to be comfortable explaining how to do this. First thing you're going to do is inspect for general appearance, looking at the skin, checking the lymphatic drainage areas for any visible masses or enlargements, looking at the nipple, making sure that everything is anatomically in the correct position. And you're going to check to see if there's any retraction of the skin or nipple area when they are moving their arms up and down. You're checking for retraction. Inspect and palpate the skin. You're going to also palpate the lymph node area, which you can see there using your 4 fingers pressing inward. The skin normally is smooth and even color. You want to know any localized area of redness, bulging, or dimpling. You're looking for skin lesions or focal vascular patterns. You might see blue vascular networks visible during pregnancy most often. You might see linear striae or stretch marks also following pregnancy, but not always with pregnancy. Hyperpigmentation, you're looking for redness and heat with inflammation. You're looking for any unilateral dilated superficial veins in non-pregnant women. You're looking for deviation in the nipples. Are they pointing in different directions? You're looking to see if there's retraction or inverted nipples. Recent nipple retraction that wasn't there before signifies acquired disease. Retraction can occur when there is a internal mass pulling at that skin area. With palpation, again, make sure you are draping the areas that are not being inspected appropriately. Position your patient. So, in nulliparous women or women that have not been pregnant before, the normal breast tissue will feel firm, smooth, and elastic. After pregnancy, this tissue usually feels softer and a little bit looser. With the premenstrual enlargement, it's normal from increasing progesterone. So during that premenstrual period, you might get this engorgement. And so sometimes patients will say that it's more tender and more full. Heat, redness, and swelling in someone that is not lactating or not breastfeeding, or if it's in a non-postpartum breast, this indicates some type of inflammation. Sometimes with a breastfeeding woman or a lactating woman that has heat, redness, and swelling, they may have a breast infection. Now, what about that occasional woman with breast implants? You want to correctly place the implants, noticing the location beneath the breast tissue itself. So you're still going to do the complete breast exam as shown for the women without implants, because the breast tissue is going to be above the artificial breast. Pathologic discharge is spontaneous. Unilateral usually has blood or it's clear. Okay, so pathologic discharge is something that means it's indicating disease. Typically doesn't happen with both breasts. If you do note discharge, you want to note how much or how many droplets, what quadrant of the nipple is producing them, and then blot the discharge on a white gauze pad so that you can ascertain what color it is. If the lump is noted, you can use the quadrants to help you decide how to chart the location, but you can also use, again, we talked about in the last lecture, the clock. Is it at 1 o'clock? Is it at 2 o'clock, 3 o'clock, etc.? When a lump is present, you're noting location, size, shape, the consistency. So this is whether the lump is soft, firm, or hard. The mobility, is it movable? Distinctness, so is it solitary or are there multiple? You're looking for the nipple to see if it's displaced, retracted, discolored. You're looking at the skin over the lump itself in comparison to the rest of the area. Is it erythematous, dimpled, retracted? Checking for tenderness upon palpation, and you're looking for lymphadenopathy. Are there any regional lymph nodes in that area that are also palpable? There is a table within your Jarvis textbook that does a great job at helping you differentiate breast lumps from cancerous breast lumps from other common types of breast lumps. We are not going to be tested on them, but if you want a little bit more knowledge in this area, that would be a good place to start. Use this slide to practice determining how you would chart this lump. The first one, if you're looking at the slide, on the left side, I would say that this would be at a 1 o'clock, but you could also say it's at the upper inner quadrant. You also want to note how far away it is from the nipple, or you can say from the areola line. You want to be consistent and make sure that you're charting that distance. Also, talking about the size in centimeters, width, length, and also the thickness, if you can. Teaching breast self-exam, again, if you have a visual aid, this is helpful, but you want to teach them to schedule that self-breast exam. The goal is that the woman becomes very familiar with how their breasts look and feel, and that they detect any changes promptly. Actually, the American Cancer Society no longer recommends a structured monthly breast exam because too many women were detecting lumps just by chance when they were bathing or dressing. But still, you want to use this opportunity to teach the proper technique, knowing that some women will choose to perform it regularly and some will only choose to do it occasionally. The idea is having them be familiar with their breast tissue so that when they do find something abnormal, they can report it. The examination of a male breast is more abbreviated. You don't want to admit it, but you will not be as comprehensive. Combine the breast exam with that of the anterior thorax. When you're inspecting the chest wall, you're noting the skin surface, any lumps or swelling. You're palpating that nipple area for any lump or tissue enlargement. It should feel even with no nodules. And then you'll also palpate the axillary lymph nodes of the male as well. Male breast cancer is rare. However, it does happen. It usually presents with painless, firm, retroareolar lumps. You're going to note this less frequent sign of nipple discharge as well. Sometimes there's ulceration and retraction of the skin, and sometimes there's axillary lymphadenopathy also. When you are teaching for self-breast exam, make sure that you have the patient lie down and they're pressing using their 3 middle fingers. They're using a very circular motion and at 3 levels of pressure, very light palpation, a little bit deeper, and then all the way down if they can. And you're following this either up and down pattern or you're going from the nipple line out in each quadrant in like a bike spoke pattern. You also want them to do this with their when they're sitting up as well, because you're watching where the breast tissue land. Examine underarm for axillary tissue, talus bents. And then if there's any surface changes when they have their arms on their hips or on their shoulders. With the male breast, you're checking for gynecomastia. Usually, again, this is a benign growth of breast tissue, making it distinguishable from other types of tissues on that chest wall. It should be smooth, firm, and movable on most occasions. Typically, you'll see it in 13 and 14-year-old boys temporarily. Reassure them. Make sure that they have an accurate awareness of body image. They may feel a little bit distressed over this, but again, reassure them that this is normal, common, and temporary. So what causes other types of gynecomastia? It can also be caused by anabolic steroids, medications, cirrhosis of the liver, and other diseases that can be found in Jarvis. I think it's table 18.8. You also want to consider developmental care, infants and children when breast buds are developing. Note the differences in pregnant, lactating, and aging females, which we've already discussed in previous slides. Lastly, reminding you to use your Tanner staging to help with your charting to best describe how the breast development is occurring with your patient. Sample charting might suggest subjective and objective. Subjective states no breast pain, lump, discharge, rash, swelling, or trauma. No history of breast tissue herself. Does have a mother with fibrocystic disease. No history of breast surgery. Never been pregnant. Performs breast self-exam monthly. For your charting, please do a subjective history on your patient. male or female. This will change depending on your partner in lab. Objective, inspection, breast symmetrical, skin smooth with even color and no rashes or lesions. Arm movement shows no dimpling or retractions, no nipple discharge, no lesions. Upon palpation, breast contour and consistency firm, homogeneous, no masses or tenderness, no lymphadenopathy. This is an assessment of healthy breast structure, and this patient has knowledge of breast self-exam because you've promoted that. Please do not assess your patient in lab. The objective findings you can pull from this example charting, but do try to recreate the subjective history based on your interview with your patient. If there are signs of retraction and inflammation, please look at page 404 to see examples of dimpling, fixation, edema, or peau d'orange, deviation and nipple pointing or nipple retraction. And here you can see different types of abnormalities. You can see dimpling of the skin, retraction, peau d'orange. You can see skin tethering, inverted nipples. Please look at your Jarvis for abnormal findings. There is benign breast disease. Typically, and previously, it's been called fibrocystic breast disease. So you may see it still charted at that in someone's history, or they may refer to it as that. Breast lump can be cancerous though, and it also can just be fibroadenoma. Now, fibroadenoma, these are benign masses, usually detected in late adolescence and early adulthood. This is most commonly when they are found. They're usually solitary and non-tender. They're solid, they're firm, elastic. They're round or lobular, usually 1 to 5 centimeters, and they're freely movable. So they're slippery when you're palpating them past your fingers. It slides easily through tissue. Versus a cancerous nodule, usually is solitary, unilateral, typically 3-dimensional, and non-tender. They're hard, they're solid, they're dense, they're fixed to the underlying tissue. Or the skin, as cancer becomes invasive, there becomes irregular borders, poor delineation, and it starts to grow constantly. If someone is at a higher risk, instead of waiting till 40, you may get a mammogram at 30 years old. Again, most commonly, breast cancer is found in the upper out quadrant or the talus spence. Hard, irregular axillary nodes may accompany this area: skin dimpling, nipple retraction, elevation, and discharge. Fibrocystic benign breast disease. Multiple tender masses with swelling. There's tenderness, nodularity, dominant lumps, nipple discharge, infections, inflammation. Sometimes you will find firm bilateral mobile nodules, well-demarcated, rubbery, dull pain, heavy, cyclic nodules. The cysts are discrete and fluid-filled. Fibrocystic benign breast disease most often will be found bilaterally. And then there are disorders during lactation. There's mastitis, which is more commonly called a breast infection during pregnancy. It could worsen to a breast abscess. And typically this will happen because there's a plugged duct. This next picture shows severe mastitis and could now have been elevated into a breast abscess. Mastitis can also look like that as well, a little bit of erythema. You can use this chart to differentiate breast lumps. Again, however, you will not be asked to do this in our class, but for your knowledge, fibroadenoma, benign breast tissue, and cancer. The main abnormal finding, going back to gynecomastia, the main abnormal finding in males, So this table also shows you non-drug reasons for gynecomastia. You will not be tested on this. Thank you for listening, and we will talk more about this in the male and female GU systems.